All right, so we do have sign language interpretation. Jason and Tylen are here with us. Thank you. So good afternoon, good evening, good night, wherever you are. Welcome to our inaugural virtual speaker series brought to you by the SMA, Society for Medical Anthropology. As you know, the SMA co-sponsors the SFAA's annual conference every other year, so we missed out on a formal gathering this year. But there are several recent updates that are worth mentioning. The first one, of course, is the update to the SMA website, medanthro.net. We do have a new look, a new logo, and a more integrated platform. If you hadn't had the chance to check it out, I encourage you to do so. You'll see that Medanth quarterly components were added. They were previously separate, and they're all have been added to the website. So the entire executive board has been busy in many ways on the back end. We're also now on Blue Sky and LinkedIn, and I'm going to be adding those links right now to the chat. So you should be able to access those. Right. The SMA has made a concerted effort to address equity concerns as they pertain to minoritized and vulnerable scholars. Last year, we had the SMA Travel Initiative, which was spearheaded by Chelsea Carter, who was the mentoring committee chair. She has since cycled off of the executive board. But based on the success of that, we're offering the same initiative for this year's conference in New Orleans. This time, the initiative is being led by Dr. Jessica Harden, with Narelle Warren and myself also on that committee. So please pass around word of that initiative, as it's designed to help support and in turn create some visibility for minoritized scholars. This includes those who are non-Western, non-global North scholars, those with precarious employment, and those who may belong to communities historically marginalized. If you have any questions about this, please reach out to Dr. Harden. But in the spirit of this ethos towards equity, we also believe it's our responsibility to create visibility for work being done in such settings as well. So this virtual speaker webinar or this series was created with the intention of highlighting the work of medical anthropologists doing important work, particularly in the Global South. Unless you happen to make contacts with such scholarship or do work in those areas, most of this work can often go unnoticed by anthropologists. The more that we can tear down our own silos, the better. And of course, we come by this honestly. Many of us are applied anthropologists, and our work with communities is by definition local, which is why this series can serve to introduce you all to researchers doing work you likely might not have heard about. So today's speaker really does exciting work in Guatemala. She works in conjunction with various health and other professionals, as well as Maya healers and community leaders. Dr. Mónica Berger González leads the Green Health Initiative in Guatemala. She received her PhD from the Swiss Federal Institute of Technology in Zurich and regularly collaborates with health professionals and researchers. The transdisciplinary nature of her work is both valuable and necessary for the kinds of anthropological impacts I think we'd all love for our discipline to have. Monica's work is concerned with issues of intercultural health, ethnomedicine, and intellectual property of indigenous knowledge. And I believe these intersecting concerns with health, epistemological crossings between medical systems, and ethnomedical ethics will make for an insightful webinar and hopefully some discussion. So without further ado, I'd like to introduce Dr. Mónica Berger González.
Thank you so much, William, for the kind introduction and the invitation to showcase the work of many, many, many scientists. So I'm going to be a bridge person today, in that I will be bridging the knowledge of a lot of scientists from Maya background and Mestizo and other backgrounds. And I'm going to try to keep it simple and perhaps foster a discussion about how you guys, from where you're standing, see some of the propositions that we have here in Guatemala. So let me start. Please let me know if you can see the change of screen. Sometimes this gets stuck. So a little bit of context. Guatemala in Central America has almost half of our population is indigenous Maya from 21 different ethno-linguistic groups. So besides 21 Maya languages, we have Spanish, Xinca, and Garifuna. But we are even a very multicultural society, not enough an intercultural society. There's a lot of racism here in Guatemala. And there's also a severe issue with human development. The majority of our population is under the poverty line. So as most of Latin America, we have a complex colonial history and recent civil war. So you may have been here in the city. It has everything cities have. But at the same time, there's this impression that we have a rich folklore. But this utilitarian notion of Maya people for a tourism industry has been a bit pervasive in not realizing the equality of knowledge systems and their contributions to healthcare, medicine, production systems in agriculture and agroforestry, and beyond that. So that's a map of the linguistic areas in Guatemala. My work has been mostly in the Petchi region to the north and Cachiquel in the Central Highlands, but also came from Quiché, Mam, Mopan, Tutujil regions, as you'll see shortly. This is probably what you'll see when you Google Guatemala, either this or crime statistics. But it is definitely a richly biodiverse culture. So one of the 10 most mega biodiverse countries in the world. We have rich heritage from pre-Hispanic times, the Maya civilization, through colonial history and to today. But the part that I want to focus on is not necessarily the prettiest. And as medical anthropologists, we deal with access to healthcare a lot. And from a critical school of medical anthropology in Guatemala, we've been studying how and what coping mechanisms exist for citizens from our country that are excluded systematically from healthcare. So we definitely have great inequities and inequalities. The map here to your left shows indigenous areas or map. So the red areas happen to be the most poor in Guatemala, also the ones with the highest indigenous population. And the purple circles show the distribution of healthcare facilities from the government. And you can immediately see that the poorest area receive the lowest of the healthcare budget. So this has created a need for diverse health-seeking strategies, and traditional medicine in particular has been the solution for up to 2/3 of our population in Guatemala and in Latin America. But we have plurimedical systems in inequity. So we have a coexistence of these very precarious public health sector services rooted in allopathic medicine, modern medicine, coexisting with the ancient traditional Maya systems, along with other indigenous traditions. I will focus today on Maya medicine because it's the root of my research. Now, when I say inequity, I mean there are not enough policies and not enough programs dedicated to a respectful coordination between these medical knowledge systems. There have been efforts to integrate midwives since a long time ago, since the 80s, into the healthcare system. But most of the attention models have to do with how do we make them do what we want, rather than understanding traditional ways of healing and well-being, and being able to create attention models that are more culturally pertinent, acceptable, and that place value on this ancestral knowledge. There are some, however, not the majority. So the work of several NGOs like Instituto de Salud Incluyente, Walk, and others are trying to have these integrative models, or at least models that are based on intercultural roots. So one of the first questions that people ask me is, okay, here you are trying to, because this is what I try to do in my research, is how do we build a bridge between allopathic medicine and public healthcare and this rich indigenous tradition that has solutions to healthcare problems when there is such mistrust? I mean, it is rooted in historical trauma due to the civil armed conflict that we had in Guatemala for 30 years, where the majority of indigenous population was persecuted, assassinated, and there's a big scar in our social fabric. So there's a colonial history of exclusion all the way to modern era. So how come we can work together? And our answer has been rooted in intercultural transdisciplinary processes. Now, when we talk about transdisciplinary, I'm not using there's a definition mostly rooted in the North American tradition, implying really deep interdisciplinarity. I'm using the definition more from the epistemologies of the South, Boaventura de Sousa Santos and others, that explain this as stepping out of our disciplinary roots as the only way to create scientific knowledge, transcend that, and include other epistemologies, other knowledge systems, to create an ecology of knowledge systems that includes those voices marginalized. Because when we think of papers, publications, theories, in our own research in anthropology or medicine, we go out and study or work with indigenous groups, thinking we'll learn something to advance maybe theory, method, but still rooted in our own conception of how things work. It's less often that from the roots of our indigenous knowledge system themselves, we can extrapolate and contribute to new theories and new models that explain whatever, that are really rooted in that epistemology. So in transdisciplinary processes, we work in joint problem definition. From the start, we may write a grant that addresses X problem, but we revise it together with all the correct stakeholders. So there's one big principle called partnerships at equal footing, where scientists from academia, and in my case, I've been working with Guatemala academia in Del Valle University, with Swiss TPH, with Basel University, with ETH, Zurich University, and others. And so we work at equal footing and create this kind of governance body that you see here in this drawing, where there's a steering council and a co-leadership at equal footing, from choosing representatives of the communities organized through Maya councils of elders in my case, or COCODES, community councils for development, and government representatives, because the nature of my research has been to impact public policy. So there's a bit of advocacy, like how are we using our research to change something that perhaps needs to be, readdressed. So in my case, Ministry of Health, the ministry in charge of animal health, MAGA, and others in environmental governance. And we've had partners from industry, private companies, and how we create a governance systems where we can all do joint problem definition sometimes, and in my case, every time communities do involve in research, get involved in research and get a salary, and we train indigenous so leaders for doing research with us, and then analysis and application. And the idea of this is that we start to break this paradigm that only some kinds of elders or people are like top scientists. And I usually show this picture down here because it is part of our proposal that Tata Juan and this gentleman with white hair are scientists in their own right, in their own epistemology. And so this came in the root of our research from a project called MACOC, Maya and Contemporary Conceptions of Cancer, where we wanted to relate two knowledge systems, right? And this was quite complex because it was the first time we were doing it, but it allowed us to understand what questions to ask. So working with doctors, epidemiologists, oncologists, psychoneuroimmunologists, and a bunch of others in medicine showed me as an anthropologist the difficulties of bridging completely disparate knowledge systems, right? One rooted in cells and DNA and pathways of mutations leading to cancer, and the other one rooted in a bigger, larger concept that included more than the body, that includes the mind, the feelings, the energy system, the the soul, the energy of not only us, but larger systems. So how do we create methodologies that allow us to relate two very different knowledge systems around a public health concern? So why cancer? It's a chronic disease. Yes, we haven't solved our own burden of transmittable disease, but non-communicable disease like cancer is on the rise here and most parts of the world. So at the beginning, we went back to the basics and started asking the question of how do we share knowledge? How is the perception of the basic constitutive elements of life and the human body? Because we jumped right into oncology. We jumped right into, okay, what's your treatment? How do you conceptualize cancer? How do you treat your patients? What are the outcomes? Let's write protocols to compare. And in reality, we didn't even have a common language to relate. So we started by sharing very specific principles to the elders, the oncologists sharing how they viewed cancer, and my elders showing oncologists how they understood the 13 constitutive elements and the 20 nawales and how these regulate the body and so on. So we kind of needed to find formulas like E equals mc squared, right? So you can start any system from the perspective of matter or from the perspective of energy. And finding these common places of grounding allowed us to move on, right? But there are things that are so strange. Like imagine oncologists having to understand this principle of how to apply the 20 nawales, correlated to a fractal conception in Maya medicine. Fractals meaning from the smallest microorganism to the largest conception of planets and the cosmos. There's this repetition always of 13 by 20. In the case of DNA, there's 20 amino acids originally before we started synthesizing new ones. So, and 13 in the scale of pH, there's this system where life can exist. And so we started sharing these bits of knowledge, right? The red dots are the 13 movements in the human body and the 20 fingers that create these mathematical conceptions of time and space and how we humans are affected by it. And so sharing this with doctors and sharing the origin of this knowledge, like this is the Cholqih calendar, showing the correlation of 13 by 20, which produces 260 permutations or days that are exactly 9 months. The time it takes a baby to be, cooked inside the mother's womb. Then doctors started to realize, okay, so all these things that seem esoteric actually have very concrete applications in healthcare. Okay, a calendar that measures life in cycles of 9 months must be very, very interesting because according to the elders, this is the one that explains human life on Earth and our health and illnesses. But these knowledge systems are applied very, very critically to healthcare. So I haven't been able to show you the whole thing because it would be too much, but When we were working with healers, documenting their own research, which are daykeepers, spiritual guides, the herbalists, and different types of specialists. We work with 65 communities and healers in this MACOG project, documenting all of this and sharing back and forth. And so they came up with diagrams to explain how elements of treatment work together, how the physical body, the mind, the emotional body, and the spiritual bodies are integrating in very specific patterns of treatment. So in the MacBook project, by sharing this knowledge with really critical oncologists from Europe, we were able to work on then applications of this knowledge to, real health threats. Like this is one of the case studies we were following on this man. You can see here a stage 4 carcinoma in his face. This looks like a big baseball, black tumor, diagnosed by Nana Panchita here on the left of the screen. But when we look at how is this ancient knowledge applied systematically to treat this kind of really severe disease, we begin to uncover the potential for mutual learning. I apologize if I don't go into every detail because we don't have a lot of time, but I wanted to give you a general overview of applying concepts like the Kartsuk, which is the balance of these 4 elements you see here in the square. The body or matter represented by fire and red, the thought or mind process is represented by wind and white, the emotional state of a patient represented by water to the south, and the spiritual part represented by black Mother Earth elements. So you have these north, south, east, west, but the most important cardinal point is east, where the sun rises, red, fire, and apparently all of these very spiritual knowledge has just a poetic side to it and seemingly no medical application. But in looking at treatments, we began to see the systematicity of how this epistemology conceives the human body, how they conceive a sick patient. And in the case of the man I just showed you, his treatment involved all 4 aspects of existence. He was sad and felt guilty for his wife's death and couldn't comprehend being here without her. He had susto, which is a syndromic approach to describing a post-traumatic stress disorder, and it's a category of its own, in my knowledge. And so all of these things were diagnosed, and a treatment was devised for each one of these categories. But the cylinder in the middle also represents a Maya cosmogonic approach to the individual is never alone. It's part of a larger system. So the patient, in receiving the 4 types of treatments, was part of a family, a community, a larger ecosystem. And so treatments were also offered to the family of the patient to restore balance with the larger community he was part of, through ceremonies, through talks with the family. And so some people ask, are these levels even creating an effect for recuperating balance, which is the main principle in Maya medicine? You can see here the effect of the treatment after 4 months. We had an oncologist, Dr. Garzusi, checking all these cases, and he said, even cosmetically, like you don't even have to prove to me that he has no cancer anymore. Even if he did, just cosmetically, it's impossible to have this result in what I know. Like I would have had to conduct surgery on his skin and basically leave a hole in his face. So Nana Panchita worked with him using photosensitizers, which are species reactive to the sun, mixing certain compounds of plants and doing all of these other spiritual and changes in diet and many other things. But the point is then that if you see an effect and you document it thoroughly, then the question that very skeptic doctors begin to ask is, why did it work? What can we learn from this? And sometimes I've noticed in research, you have to start showing some sort of relevance of the research before you get the others interested to engage at equal footing. It's been a problem to create research environments in transdisciplinary fashion where an epidemiologist graduated from Harvard is willing to engage seriously with a Maya who never went to school. And until these cases are shown, then there begins to be a bit more of a cultural humility on the side of scientists to engage. And this requires patience, because usually it's up to us, the medical anthropologists, to design the methodologies for mutual learning, as I've seen it so far. And so the other example I wanted to give you was that of a One Health approach that we started researching to create a surveillance and community-based response system. So this was about zoonoses in this area that were really not tackled, understood, or for which there was no evidence but high suspicion that they were existing in the area, specifically leptospirosis and brucellosis. And the idea was to have a cross-sectional epidemiological study to see how much the disease was or had been in the area, then establish a community-based syndromic surveillance system where traditional healers and traditional midwives were involved, and transform that into results for policy and education and other actions. So as you saw this before, we engaged the government, Fundación Tigo, a telecommunications company, to provide for free the mobile application for real-time or near real-time syndromic surveillance in really isolated communities and different councils of elders. So we were co-designing this together, right? And you might remember that I said, a huge principle of transdisciplinarity is defining interests at equal footing. But this is really, really happening. This is a typical picture of how a kickoff meeting would look. And then you have to ask, okay, who's sitting here? And we decided to start doing something called backward planning to check our assumptions in research. So we knew our goal was to co-define project interests together. Okay, how does a midwife and a healer view a syndromic surveillance? What's useful about it? How will an epidemiologist from the Ministry of Health view this as useful? And what do the scientists like me and others want to get out of it? And so we all had different interests. And the idea is, okay, we're going to co-define the project interests. And we didn't assume we had it. So we check our assumptions. We assume that we all have the same chance to express our interest and negotiate the outcome. So then we check each assumption. And this reality check asks, who's in the dialogue? What's the context? And so we ask these questions you see here in the screen. I mean, sometimes we have so many disciplines and we fight across disciplines. Interdisciplinarity is already tough. How does an epidemiologist conceive data collections? Very different than a nurse, I can tell you, and very different from an anthropologist or a biologist. And so we had disciplinary cultures, ethno-linguistic cultures, different knowledge systems. And so by asking these questions you see here, we begin to understand complexity and diversity. And the first reaction is people get scared in the team, like, oh my God, how you really want to take all of this in? How? And so we also look at how many value systems. For me, I mean, this is an issue with my colleagues in Europe is, we need reliability in the data. We need accuracy, objectivity. But to the healers, it's more important to keep the peace and build trust. And so how do we coexist in even those values? And the first thing was, okay, get everyone who's here. There's a nurse, there's a healer, there's a linguist who wants to understand how to tackle emic categories for surveillance. I mean, I call it fever, but what does the Kikchi call it so that it's effective? And so on, right? My healers, people from government. And this complexity means everyone wanted something different. The community wanted just a clinic. They didn't care about a surveillance system. They want attention, medical attention. So if we create a surveillance system with no healthcare options that are really occurring in their communities, they're not gonna inform of anything in the system, right? So the bigger divides were, of course, the Maya epistemology and the Western epistemology, and then it's a question of how do we bridge them. So we start by a lot of exercise on reflexivity in transdisciplinarity. And here you see a bunch of things that we ask these questions. What are the language barriers? What are the historical and structural barriers so that we can really define interest at equal footing? What are issues of access, geographic, education? Oh, women are not sitting here. Why? It's only Maya males. What's happening? We soon realize that until we hang hammocks in the meeting rooms, the women are not going to come because most of them have babies or are taking care of young children. And so all these questions on hierarchy and racist attitudes that exclude people from the group, we started to show us who was not sitting in the room. And so when we have this real context where we see multilingualism in inequity. So right now I'm using English. Y a menos que muchos de ustedes hablen español, no van a entender nada de lo que diga ahora. Right? So if I switch to Spanish, maybe I'll lose many of you. And then if I start saying I'll lose even more of you. And that's what we do in research. We choose a language and then we kind of control for the probability of excluding people, but it's hard. To include everyone. And so in transdisciplinarity, we look at these issues. What are all these issues of literacy? What is the language level I have to keep in a meeting? And what are micro-invalidations that my teammates have? Our mighty epidemiologist who won't step down his mighty white horse to talk with the elders at equal footing. How do I help that to change? And so when we see these conditions of power differentials, unacknowledged diversity, and a high risk of ventriloquism, we talking for others, we create modulators of change to really get to everyone co-defining project interests, which was the first step of a transdisciplinary approach. And so we do things like this. Translation from English to Spanish and Quechua to Spanish. So elders are listening in Quechua, everything we're saying in Spanish. Our guests, international guests, are hearing in English, and we use Spanish as a lengua franca. But then an elder can speak in Quechua, and someone will hear it in English. So they don't have to compromise how efficient their way of communicating is. I'll never be as fluent in English as I am in Spanish. It's just the way my brain is wired. We do exercise to, in this case, raise awareness about diversity by topical things. So here we're talking about a One Health approach. Therefore, we started doing exercises about how do we relate to animals and humans and exchanging between little groups. So someone could see, wow, for me, chickens are not as important as for my Maya colleague. For me, a dog is a son, but to a Maya healer, that's just like a guardian. So understanding diversity in little exercises allows us to then get to the toughest parts of watching ethnocentric biases. And we design a lot of exercises like this one. Like how do we show pictures like this one and ask each one in the audience, what do you think you're seeing? And we make sure to include from all different cultural backgrounds and then share in plenary session. And people begin to see that, oh, where I saw assumed in epithelial cell cut with ink to show a metastasis, the elders saw a fungus in corn. Or where the Europeans saw red beans, the elders saw the sacred bundle, the pichoncacal, that healers used to in medical divination and applications and spiritual applications. So the idea is that we have to force people to become aware of emic and ethic interpretations in transdisciplinary research. Otherwise, everyone will be always having all sorts of assumptions. So this is not only for anthropologists. What I want to say with this is that we train everyone in the team in Europe and Guatemala and the Maya communities to say, you know, I'm explaining this from my emic perspective. Just try to understand. And just, it seems crazy, but that solves so many problems. And then we would have exercise to equalize power differentials in defining interests. I'm not going to go into those, but the point is that these are modulators of change in transdisciplinary research, to leverage the floor, to bring reflexive exercises. So when we were done with all of these things, we could then move into co-defining project interests at equal footing and defining, okay, this project is going to deal with A, B, C in this manner, and all of this is out. So those democratic decisions allowed us to then complete this task of estimating the prevalence and incidence of leptospirosis and brucellosis. So I always show this to say, we can have beautiful design methodologies as social scientists, but if we do not reach the medical goals and the public health goals, no one will want to work with us again. So I always try to keep the ideal methodology with what is feasible in the time frame and the budget we have. And so we were able to create a beautiful syndromic surveillance system and estimate these prevalence and incidence to show that a transdisciplinary approach works. And so again, how do anthropology brings in all of these aspects, in this case, to co-design and one health surveillance and response approach to see the health of humans and the health of animals at the same time. And we began to see that it was linguistic analysis and ME categories of surveillance that we needed to understand. So again, the same backward planning process of how do we build a sensitive community-based disease surveillance system. We check our assumptions and our conditions. I'm going to go a bit faster on this. And we come to realize that, again, we didn't understand the categories of surveillance between maiemics and what epidemiologists want to have. And so we started by doing exercise defining ME categories for surveillance. So you can say someone has a temperature when they have 38 degrees Celsius or higher. In Spanish, we can say temperatura, fiebre, calentura. And in Kekchi languages, there are many categories of fever. Cold fever, warm fever, fever of the head, fever of the stomach, and then which one are you surveilling for if we're not precise with the names? So having this collaboration with traditional healers, traditional comadronas, midwives, helped us create a surveillance system that was pictoric, didn't need high literacy levels, and was being useful for local communities. And here, I just want to show you quickly, these are each column in the red squares is a different system of surveillance, and this is ours, the One Health Bactum project. And you can see that it was a lot more sensitive than the others. So the incidence was 139 per 10,000 people a year. And why is it so much higher than the other, the national surveillance or the passive surveillance? Because it was rooted in the community, it was done in the local languages, and it was the local healers that were documenting the existence of these cases at homes. So naturally, what we realize is that transdisciplinarity caused this method of co-designing together created a larger impact in a more sensitive community surveillance system. And this was what we needed to do to start pushing the envelope with the public health system to say, look, if surveillance is more successful when we engage the community, would treatment be more successful if we do the same? And so we realized that doctors and healers didn't trust each other, didn't want to work together, and patients were caught in the middle. So we started using boundary science and patients as bridge systems between these two cultural divides by having a patient be diagnosed at the same time by a doctor, MD, and a Hilonel, and have them discuss the case together. So without going into much detail, what started to happen is that one saw the value of the other. And when they had to discuss treatment with the patient was when the thing became really interesting because, of course, you know, in leptospirosis, you have to go into the hospital to get the shots in your veins. And in Guatemala, they have to stay for a month in the hospital to make sure that they don't leave and come back for the second dose. And no one wants to do that in these isolated communities, so they don't go to the hospital. In the Maya healers' way, they were looking at traditional remedies with plants and calling the soul back in the case of this patient. And so they were discussing treatment, and the interesting thing was that the patient integrated both very quickly every single time. We have 32 patients as case studies, and every single time the patient integrated both remedies by saying, hey, I want Tata Andres to call my soul back, because if I go to the hospital with susto and my soul is not in my body, I will die there. And the Ahilonel said, I can give you plants to call your appetite back because you're too skinny and you have a urinary infection. I can give you plants for that as well. You have diabetes, I can give you plants as well for that. And then you can go to the hospital. So the idea was that then they ended up accepting an antibiotic for urinary infection and the leptospirosis treatment in the hospital. Whereas before, these patients would have never gotten treatment in the public healthcare system. It's so foreign, the concept of treatment, the way we conceive it in allopathic medicine. So what I wanted to say is that by design, this methodology was aimed at showing and creating a proof of concept to both sides that they could trust each other and work with each other to a degree. So of course, the MDs never attended a Maya ceremony for calling back the soul, but they learned to respect it and stop calling it witchcraft. And I'm gonna skip some of these slides, but we had anthropologists also understanding how inextricably the health of humans and animals are in One Health approaches, right? So these are some of the elders that are working with us when COVID-19 hit, and we kind of changed the focus to understand COVID treatments as well. And so by starting to collect all this data through participatory methodologies as well, we started to understand how to curb restrictions. And understood a bit of the forest challenges. So this map shows you the red dots are how fast we're losing our forests and therefore the natural pharmacopoeia. So when we started to go deep into Maya medicine, we realized that these medicinal plants are going to be gone very soon. And changing the focus from what is of interest to me as an anthropologist and shift to what's of interest to the Achilonel and the Achich themselves, started to show a different way to understand plants and how they relate to the human body and to heal. And that's when the Kawilal concept emerged, a Maya One Health approach, explaining that the health of Tzultaqa, or Mother Earth, of the animals and the plants and the larger ecosystem was exactly our same One Health. And so all of these categories exist in this ancient epistemology to basically say that we can understand interrelated health systems. So a real One Health concept from Maya epistemology emerged. And people have started to ask us, but how is that helpful? Is that useful for something? And just to give you a very quick overview, we turned this concept into a community guide for risk assessment to zoonotic disease outbreaks. So we created indicators for each one of these Kawilal areas and developed it into a guide with participatory methodologies where communities could self-assess how much at risk they were in this aspect, and working with, again, traditional comadronas, midwives, and healers to turn it into a very practical, usable, step-by-step system where you only need some people that can read and write and direct and create something that looks like this that allows you to check modulators for health risks. Now, without going into all the details, why did I choose to share this with you today? It's because often in medical anthropology, we're challenged to make our research relevant beyond the specific research question that we had in a project. How do we keep building on it and building on it? And the answer is when we pay attention to what's necessary at the community level, they tell us how our research can be relevant. So this self-assessment guide has already helped communities to leverage funding for their water supplies or for soil degradation problems, because it has emic and ethic indicators that measure things like, okay, water quality, very simple, and things like Tzultaqa Kawilal, health of Mother Earth, that is designed in a participatory methodology by the community. So they get to include both categories of risk to say, okay, the forest is disappearing. More bats are biting our children because there's no mammals in the forest to eat from. So more risk of zoonotic disease passing to us and our animals. And so this logic is what we've seen translated into potentials for changing stuff around. The same from this Kawilal guide, the midwives, the comadronas, the traditional healers in the community say, well, it's great to have a guide, but how do we create our own surveillance system now? And so they asked us to help them create an app in Qebchi language that uses sound and pictorial images to help midwives report danger signals to the Ministry of Health and receive help right away. So without going into the details, I just want to end by saying that it is really up to us in our research to have these really strong transdisciplinary orientations and collaborations, because that's how the research becomes more relevant for the communities themselves. And this app, we hope to launch a second version soon. And in the end, if you give me 2 more minutes to finish, we have these North-South partnerships in Latin America that do require sound inter-epistemic dialogues. And this is complex to tackle. So in transdisciplinarity, we always start from a complex real-world problem. We don't do like pure science, in lab. And we need collaborative approaches. But that means we have different interests and different degrees of power and agency. And when I put here the question mark is, what is the outcome of all of these? Because we can always have 2 outcomes. We can have pluriepistemic landscape, where we have real participation at equal footing of all stakeholders, where mutual learning happens and when knowledge is co-produced and not imposed on a group. Or we can have the usual, in my case in Guatemala, the usual healthcare outcome, which is a monoepistemic approach, where we put makeup of participation. Oh yes, people came and consulted and gave us their opinion. It was not really participatory. And there's this neo-colonial approach to, it's horrible to say it, but it's almost like a civilizing orientation through healthcare and not really a dialogue. So we are sanctioning the epistemicide. What I mean by that is we are agreeing that science is used to silence other ways of knowing in healthcare. And the point is that we have seen through intercultural transdisciplinarity that robustness is increased when we have 2 columns to a One Health approach. Obviously, one is having scientifically robust orientations. So we have to be very good at what we're doing, disciplinary and interdisciplinary research and application. But the other one is socially robust solutions. So how do we engage with societal stakeholders? How do we get the potential of consensus to be higher? How do we co-produce knowledge that can transform their reality? And that's why we really advocate for this transdisciplinary process as the method to create these feelings of representation, because participation was real, because there's pluriepistemic validity, because there is cultural adequacy or pertinence. So we've seen through, I run now like 7 different transdisciplinary projects in public health, and we see the uptake of the outcomes in public health being more robust, even at the government level, by including the people from the public Ministry of Health and Environment. They were more willing to translate that into policies at the regional level that changed hospital care and changed a way to relate with midwives, that adopted the app and so on. So I think it goes always. And the last thing I want to say is that we've seen probably this framework of access, where we have a supply and a demand side, and from the interaction of this plurimedical system in the supply, traditional healers, hospitals, private practice, and so on, in a very strange landscape, matching the needs of patients in their help-seeking pathways. We see these 5 dimensions of access that probably we've all, at some point, researched. Is the access really accessible, available, affordable, acceptable, and adequate? But what I want to add is that we often forget something else, which is that these pluriepistemic, these plurimedical systems like Guatemala, like the US, everywhere in the world these days, have hierarchies, and they have interferences between them. So what a public health post in a small community wants is not the same as the main policy at the central level. And there are clashes there. And there are also clashes with the interests of communities and different groups. So that's postulate 1, that there are hierarchies and interferences, and that there are disparate interests. And the question is, how do we solve for those to really have access to healthcare? And so we want to propose the 6th A, which is we build agency. So if we, as medical anthropologists, can build pluristemic alliances through social participation, we might be more successful in creating agency for the stakeholders that usually don't get to decide on their healthcare outcomes that well. So that truly the utilization of these healthcare options increases health status and patient satisfaction and equity. And I'm gonna leave it at that because otherwise it's gonna be too long. But I just wanna thank you for letting me speak to you a bit about intercultural science in Guatemala, and end with a tone that it's not meant to be grim but realistic. So I showed you this picture before, and sometimes medical anthropologists, we don't know what we're getting ourselves into or what we're getting others into by pushing participation in non-democratic settings. And so he was, Domingo Chokche was one of the elders with whom I work, who was considered a scientist when we went to Europe with him and when European scientists came here, but was considered a witch in his own country. And he was burned to death, burned alive. And his death marked also a tragedy of other elders being persecuted because there's so much there's such a big unknown and fear of what is different. Oh, he's a witch. Why? Because he burns candles that are red and black. Why is that supposed to be? Obviously, people don't know about the cardinal system in Maya epistemology. But if we could share this knowledge, perhaps the fear would decrease. And from this sad event, a lot of others have been working together to turn our research not only into meaningful public health interventions, but something bigger. And so how do we make our research have an impact locally? And I want to invite those of you who are interested to visit the Green Health Platform. Maya elders, traditional healers, scientists, and anthropologists, and others working together to create spaces for mutual learning, including Mesoamerican Institute of Indigenous Ethnomedicine. So I leave you all with this question: how can our research become meaningful for more than ourselves? And thank you. Thank you so much for your patience so far. So I would like to open it to questions, Will, if you think it's now's the time.
Hi, everyone. I think we probably have time for a question or so. Does anyone have any questions or comments?
Dr. Will. I have a question or a comment, actually. Let me share my video. Hello, can you hear me?
Yes, Ingrid, I can hear you. Please go ahead.
Hi.
Hi.
Hi. So my name is Ingrid Panamenyo, and I'm a student of Professor Dr. Lucas at Dominguez Hills, and I genuinely appreciate your research. I grew up in a Salvadorian household where my mother relied on natural remedies before turning to the doctor, and this highlights not only like the personal connection, but it also raises, the broader question about what you brought up, ethnocentric bias in medicine, and how we can encourage scientists and doctors to be more open to these practices. And I really resonate with how you brought up what are considered witch doctors are now scientists, which I I love a lot. And how doctors realize that even though they didn't show up to the returning to the spirit to the soul ceremony, they respected it. And so my mother had a stroke last year, and we went to the doctor. We did all these what you are supposed to do, right? Go to the doctor first, and nothing worked. So she went to El Salvador, and we went to our healer. My mom is healed, comes back, and she can move her arm. And it's funny because the doctors did ask my mom, well, what did you do? Did the physical therapy work? And she told me she was too embarrassed to say, well, I went to a healer back home. And I'm going to talk to her about your research and get her opinion on it and see if she wants to open up to her doctor. And thank you again. Very inspirational.
Thank you, Ingrid, for that story. It's I hear a lot of these cases, and I guess I hope that our research helps people not be embarrassed anymore, because this is science. Indigenous traditional healers are scientists in their own right. So hopefully we'll get to a time where we can proudly say we visited a scientist in El Salvador, an indigenous traditional healer. Thank you.
Thank you.
Maybe we have time for maybe one more question, comment. And you can feel free to put it in the Q&A if you'd like. All right, so we have one from Gregory. Thank you so much, Monica, for a truly fascinating presentation. You've mentioned the Wuku Kawok project. What's your opinion about it? Do you know anything about their current activities?
So I've had the opportunity to share some of the stage with some members of Ukukawok, particularly their head of medical attention in the Cachiquel communities and areas, who's herself a Cachiquel female doctor, and also have seen their interventions during COVID-19, but mostly I met their work because of the cancer project that they were running in the Central Highlands. So I can only speak to that. And I was very impressed with their ability to bridge these horror that it causes to go to the cancer hospital to Cachiquel patients that don't know how to navigate our public healthcare system. So they had strong ties to healers and to communities, but still a very strong approach to allopathic medicine. So they were not doing integrative medicine. They were doing intercultural integration to facilitate providing the allopathic medical care, but still allowing patients to, bless the chemotherapy with a Maya healer before taking it and attending a Maya ceremony. So they were the first NGO that I saw back then that was truly trying to understand this approach to public health from the perspective of indigenous peoples and bridging all the problems that were there in seeking that attention. So I know a bit about some of their programs, and for those I know, I think they are making a difference. Definitely, if you compare what's available in the public healthcare system and what they're putting there, it's much better. It's not yet integrative care, but I don't think that's their goal. So we shouldn't compare pears and apples, right? It's just, I think for cultural acceptability and linguistic adequacy, they're doing a really good job. Thanks for the question.
All right, I think that's probably all we have time for. Thank you so much, Monica, for your presentation and everything that you were able to share with us. And I'm going to edit some of this video and post it on YouTube and post it on our site. And I'll also be sharing it with our membership everywhere. And I can also send it to you too, Monica. But
Thank you. I would appreciate that a lot.
You have any kind of like a last word that you'd like to say before we sign off?
Yes, thank you. I'm here in Guatemala, but our research is meant to be global. If any of you will have an interest to come and do an internship or a small field work, or you want to do your thesis or dissertation here, we are opening up our project at Green Health to receive scholars from around the world to help us advance evidence-based research in Maya medicine. So I would feel very honored if any of you are interested. You can write me. If you can share the email later, I would appreciate that. And thank you so much for the opportunity to showcase our work. I really appreciate it. So all the best to you in your webinar series as well.
Thank you, Monica, and thank you everyone for joining us. And I'll be in touch soon.